Avec la permission de Monsieur le Président, je pense qu'on va switcher en anglais parce qu'il y a des participants anglophones. Je pense essentiellement au Dr Akram qui nous vient de Jordanie, puis on aimerait le revoir lors de prochaines conférences. Donc si vous êtes d'accord, on va switcher en anglais, puis on va suivre aussi l'exemple du président de l'association. So we switch in English, and I think I'm not going to skip to the rule, and then I'll start by thanking the organizers of this meeting. Very delighted to be here as usual. And I think I've been given a very broad mandate today. We'll be talking about AI in nuclear medicine. And I think this is a sufficiently broad topic. I can probably talk about this the whole day. So this is going to be one of these talks where we sort of have sections. We go a little into detail. Other sections we sort of skip over. Just hope to have some time for questions at the end if anything is missing from anybody's expectations. So let's get started here. So this is the beautiful city of Geneva, the famous jet d'eau, the water fountain. And Geneva by day or night, I think is, at least to me, the most beautiful city in the world. And somewhere actually downtown, so we have the University Hospital, which is just opposite to the medical school of the University of Geneva. And then I have a nice lab there, so almost 11, 12 people working on different topics that are listed here, and today I'm going to focus on AI and deep learning. I'm obliged by my institution to disclose any conflicts of interest. I have known, actually, you have some projects funded by industry, but nothing really linked to the content of this presentation. But I would like actually to acknowledge a couple of projects. So the first one is a European project called Symphonia, 6 million, funded by Brussels, the European Union. And the focus is to use AI actually to develop advanced computation models that can be used for radiation dosimetry calculations, both from X-ray CT and nuclear medicine. And the second part actually is more dedicated to the radiation dosimetry aspects of the thing. So development of models and their use actually as input for AI-based solutions for radiation dosimetry calculations. And the second project is funded by the Eurostars program. It's 2.4 million, and also by Geneva Private Foundation. And the idea here is to develop a scanner dedicated for prostate cancer imaging. You see the prototype here on the right side, which is being tested actually extensively in our facility. And as you can see from the design concept, so it's different from commercial systems in the sense that you have kind of dual head, 2 detector models. And we don't record actually full projections because the system doesn't rotate. And to solve this limited angle tomography problem, and the thing is that we don't have also an X-ray CT on this device also to perform attenuation correction, so we need actually to use AI for this purpose. You see some first images actually produced with this prostate dedicated phantom that you see on the right side. So some of the developments I'm going to present today were also funded by this project. I thought we will have some decision makers actually in the audience, and then let me just start with this quiz here. So who knows this person? No? So this is Anders Erasmussen. This is the former prime minister in Denmark. And he said that all cancer patients who need a PET CT should get it. So he didn't say I need to talk to the Council of France to send my kids to get educated in Europe. And he didn't say that I need also to purchase an apartment in 7e arrondissement in Paris. He said that all cancer patients who need a PET CT scan will get it. And this is a second message actually to my colleagues, clinicians, and academicians as well. So this is another person. Who knows this person? No one, I guess. So this is my friend Paul Fleming, because I'm affiliated actually with the University of Southern Denmark. And this is the former chief of nuclear medicine and also the academic director of the hospital. And he said that, this recalled me actually some discussions I had with Professor Asya Mimur. She told me you have to spend the day with us to see how we deal with the patients on a daily basis. And you're talking about AI and all these advanced developments. And he said that no patient will enter my PET center without being enrolled in a study. And I think this is a clear message that in addition to doing actually the clinical management that we do in routine. We need also to do some research, and this is very important, I think, for the residents, at least in Switzerland, to get your certification, what we call the FMH. You need to publish one paper, and you cannot get one paper published without doing research. Right, so getting to the, not really an outline, but kind of list of topics I'm going to cover today, as alluded by the President. So I am merging basically the two talks in a single, so covering both qualitative and quantitative imaging. So very quickly, I'll go through the recent developments in multimodality medical imaging, and then so a few slides really, because I think the previous speakers covered this extensively. Why do we need AI in multimodality imaging? And then we will talk about the promise of AI in various applications that are listed here, starting from instrumentation to image segmentation, cross-modality image conversion, computation modeling, prognostic modeling, outcome prediction, and then we'll summarize this talk. So what is now very trendy is those large axial field of view PET scanners that were developed actually by a number of academic groups, including the UC Davis group that you see here. So the PIs of the 16 million grants allocated by the National Institutes of Health in the US, Ramzi Badawi, and you see here also Dr. Sherry in the back. They got actually this large funding to develop large axial field of view scanner, 196 centimeters, so that you can basically reduce the acquisition time or the activity injected to patients significantly. And the other advantage from the research standpoint, as you will see in the next slide, is they can also do parametric imaging. Other developments, actually some of these scanners that you see are commercially available, like the Biograph Vision Quadra, 106 centimeters axial field of view, the Panorama from United Imaging, also 148 centimeters, and the two others are not approved by the FDA. Basically the PenPets developed by the group of Joel Carr from Philadelphia, UPenn, and the Omni Legend. So the 16 centimeter actually was installed in a number of facilities, including Toulouse, that you had the chance to visit last year. But the idea actually of GE is to expand this to 128 centimeter axial field of view. And hopefully this device, when it will become available, will be also approved by the FDA. The other advantage I mentioned is that you can start doing the imaging immediately after you inject the patients. And this animation here shows basically the potential of compartmental modeling in combination with total body PETs to visualize the tracer uptake and distribution. So you basically see, in addition to the standard SUV images, which is used in the clinic with the static imaging, you can see the influx rate, you can see the delivery rates, you can see many physiological parameters that are of interest, especially for research applications. Now in the clinic, just for the young generation, probably some of the residents sitting in the back, because I think most of the senior people are familiar with the principles of PET-CT. So basically you inject your patients, you put the patients in the field of view, and you start with a scout scan, right? And then based on the acquired two-dimensional image, the technologist is going to define an axial field of view, and then you start doing the spiral CT by rotating the detectors in the X-ray tube around the patients. And then you push the detectors actually back in the back here. So because the two subsystems are separated by 60 to 80 centimeter distance. And then you start acquiring the PET scan, and then you fuse the two images together, provide them to the MDs for clinical diagnosis, monitor and treatment response, whatever the application is. PET-MR basically is the other side of the story. It's almost the same principle, with the main difference is that there is some interference between the two subsystems, because you cannot actually operate in MR having some metals inside, and then also the photodetectors, basically the photomultiplier tubes, cannot operate within strong magnetic field. So you see the first actually system designed by Philips, and this is the one that was installed in our facility for almost 12 years. It's a la PET-CT kind of design, you know, so you start with an MR and then you rotate the socket. The two subsystems are separated by almost 3 meters distance, right? So you need really pretty large rooms to install this device. And then some other design concepts which enable simultaneous acquisition of the two signals, and they use basically solid-state detectors which are MR compatible. They could be avalanche photodiodes, such as the design concepts used by Siemens on their MMR, or silicon PMTs, such as the design concept used actually by General Electric in United Imaging. More recently, just a couple of weeks ago, Siemens announced their Biograph 1 at the Radiological Society of North America meeting in Chicago. And it's very interesting design. It's the first one actually with the 35 centimeter axial field of view, and they use the silicon PM-based design, the Optizo UDR, which is a very interesting concept, and I hope that this system will be also installed in a few facilities in the future. Just to show you some images that you use in the clinic, so you see the T2-weighted sequence with the PET and the fusion of the two images, and some cardiovascular images in the bottom of the slide here. On the quantitative imaging side, so the majority of the clinics, at least what has been reported in a survey published in the Journal of Clinical Medicine, is that 90% of the clinics rely on the standardized uptake value, which is a very simple image-derived metric that you can quantify by putting a region of interest. You get your SUV max, and then you look through the plots. You see two patients here. If the SUV is decreasing, because you've got the baseline and then a number of follow-up PET scans, so the SUV is decreasing, meaning that the metabolic activity of the disease is decreasing, the patient is responding, and if there is a progressive disease, the SUV is going to be constant or is going to increase. And as you can see, the first patient responded and the second is not responder, right? The disadvantage of this is that we are actually relying on a single voxel compared to what we have actually in the whole image, so we're discarding actually the majority of the information that we have within the lesion. And here comes the concept of radiomics that has been actually in the field since at least a decade, because the radiomics concept was introduced basically to put forward that the images are data, they're not only images for a quantitative analysis. And the principle is indeed very simple. You need to segment basically what we call the GTV, the gross tumor volume, which is a concept which is used actually by our colleagues in radiation oncology. And then you can quantify a number of features. They could be intensity related, they can be shape-based, they can be more advanced or high-dimensional texture-based features. And then you put this information into what we call the heat maps, which is a very difficult actually graph that's difficult to interpret by the non-specialists, but based on which you can actually gather some important information, especially for outcome prediction, clinical prognosis, and a number of other applications. And I'm going to give you actually some examples how we can use machine learning actually for this type of applications. I'm just going to skip a few slides because I think the previous speaker already talked about all of this. What I'd like to mention here is that the major milestones actually linked to the development and the history of of artificial intelligence can be correlated with major milestones in the history of medical physics, starting from the development of the LINAC in Stanford in the 50s, development of the gamma camera by Anger, and the more recent development of large axial field of view PET scanners, PET combined with the LINAC and so on. So it's not really surprising that the Royal Swedish Academy of Sciences has decided actually to award the 2024 Nobel Prize in Physics to John Hopfield and Geoffrey Hinton for foundational discoveries and inventions that enable actually machine learning with artificial neural networks. So what is the main motivation actually? Just to hold one example from the recent reports published by our colleagues in the UK. And we believe that we're likely to see that many operation-dependent tasks will become increasingly automated. If you look just at this simple graph here, you see that they expected, well, they got already 33% in terms of shortage in the workforce. I mean, the difference between the gap in terms of radiologists available in the market and what is really the demand. And they were expecting this to increase up to 43% in 2024. Looking actually to more recent reports that was published last year, I think it is less dramatic compared to what they were expecting, but still actually the shortage is in the range of 36–41%, which is just enormous. So how to fill this gap? We believe that increasingly automated diagnosis of routine cases will be basically taken over by clinical decision support systems, and this is already taking place in the field of mammography, for instance. The majority of radiology departments that I know, at least in Switzerland, they're using this type of clinical decision systems. Radiologists will focus only on the difficult cases, and then the radiologists will not, and nuclear medicine physicians, of course, as well, will not be service providers, but they will be also involved in the clinical decision-making process. Un peu de silence, s'il vous plaît, parce que ça me perturbe. Merci beaucoup. Talking now about these figures, actually, that I took from this website of the FDA, Food and Drug Administration in the US, which approves basically the medical devices and algorithms that can be used actually for medical applications. You see that up to August 7, 2024, they had almost 950 entrees. What's important if you look to the plots is that you have an exponential increase, which means that the FDA is really flooded by the products. And the second observation that can be made on the right side is that the majority of applications are in the field of radiology and medical imaging, and second is cardiovascular. So this is very important, and there is this recent publication in the Journal of Nuclear Medicine. You see 43-year-old man with equivocal, actually, finding on anatomical MRI. And the scans were basically interpreted by radiologists, nuclear medicine physicians. So what you see here is in the thalamic region, they identified malignant disease, but they used also the images, actually, so with the fluorotyltyrosine, which is amino acids used basically for clinical diagnosis of brain tumors, glioblastoma. And they used actually the images as input to an AI-based segmentation tool that identified a second lesion that was not highlighted by the nuclear medicine physician. And looking actually to the follow-up scans, so 4 or 6 months later, they realized actually that the second manifestation that was not delineated by the physician, but actually put forward by the AI-based segmentation tool, will correctly identify this lesion because it's progressed. And it was actually biopsied, and of course it was confirmed that it was a glioblastoma. So, as alluded by the previous speaker, we don't believe that those support systems will replace the MDs, but they will be a nice tool actually supporting them. For medical physicists actually that are in the audience, I think they are aware that at least at the European level, the European Federation of Organizations of Medical Physics already amended the curriculum for training of clinical medical physicists and also the academic programs for master and PhD level. And there is, these programs have been upgraded to include an important component of AI. And the reason of this is that we expect, or we believe at least, that AI is not going to be limited to academia and to industry, but it will have a profound impact on our profession as medical physicists. And similar debates and discussions are taking place around the globe, as you can see from this paper published in Medical Physics. So the applications of AI in the medical domain really cover almost all different aspects, so from image acquisition to image processing, data analysis, report generation, detection, quantification, and quantitative image analysis. And let me give you actually some examples, starting from instrumentation. So this is actually some developments carried out by one of my former PhD students. And as you know, so the majority of the devices that are used actually in the clinic use the detector block concept, where scintillation crystal is cut into small pieces, what we call the pixelated crystals. And then you have the famous angle logic that identifies the position of interaction within the detector blocks by combining basically the output of the different photomultiplier tubes. And these monolithic crystals have been introduced actually by a number of academic groups and also some manufacturers. And they offer a number of advantages in the sense that they offer you better spatial and energy resolution and also better sensitivity. And then we decided actually to modify the design concept of this extreme small animal PET scanner that was designed actually a number of years ago, which used actually this pixelated arrangement of detectors to monolithic crystals. So we generated actually data through Monte Carlo simulations to have training data. And then we compare the performance of the angle logic, which is implemented on the commercial devices, compared to multi-layer perceptron using AI. And you see the output here, so the results, so both in the axial and in the radial direction, you see the major improvement in spatial resolution up to 18 or 21% in both directions. And if you look to the image quality phantom, you see that the small sphere here, I don't know if you see actually my cursor, but is visible on the multilayer perceptron, but you will miss it for sure if you use the angle logic. Looking again to this multi-point sources phantom here, you see that you have much better spatial resolution with the multilayer perceptron compared to the angular logic. The second development is that we know that the majority of the devices used in the clinic use either LSO or LYSO, which are equivalent crystals, but they have slightly different decay times, meaning that the decay time is really very fast, so that enable you to implement time-of-flight technology, which is very important in getting better signal-to-noise ratio on the images that we have, especially for obese patients. And then one of the manufacturers decided actually to get back to BGO, which is less expensive compared to the LYSO and the LSO crystals, but this device, this crystal, has a decay time of 300 picoseconds, meaning that it's really extremely slow and doesn't allow the implementation of time-of-flight technology. So the idea here is to explore is, can we use actually AI to generate time-of-flight images from non-time-of-flight images? And this is what we did in this study here. So we basically trained the data using brain as a nice example, because the brain can be approximated by a cylinder having 20 centimeter diameter, so you don't have to use all the time-of-flight beams. We used the Biograph MCT, which has a time resolution close to 540 picoseconds, meaning that you need to generate around 13 time-of-flight bins. So we used only 7 of the 13 time-of-flight bins. And then we did the same for the implementation in the image domain, as you can see in the bottom here. I think the MDs in the audience are not interested by the technical details, so let me show you some examples, some images here. You see in the top the time-of-flight image, which is our standard of reference, right, generated by the system. The non-time-of-flight image, I'm not sure if you see it here, but it's slightly degraded compared to the time-of-flight image, and this is well-known actually phenomenon. And you see the predicated images in the bottom, both in the projection and in the image domain. If I zoom through the images, again, not sure if you see it on this PowerPoint, but I can assure you that you see it nicely on the console that you use in the clinic, and you see some improvements actually in the spatial resolution with the predicted images, especially the one actually predicted in the projection domain. Switching now to X-ray compute tomography. This is a busy slide, so we knew the flow chart adopted in this study, which aims to assess the additional radiation dose associated with what we call overranging or overscanning. And the idea here is to develop an automated pipeline that enables to define actually the axial field of view, because we realized that the majority of the technologists, manipulator, if you prefer, they tend actually to define an axial field of view which is larger compared to what the radiologist needs. So the idea here is to generate artificially, or to use a deep learning pipeline that I'm going to present in the next few slides to segment the lungs, and then to generate the AP and the lateral topogram, and they use this actually as input for deep learning framework that enables you actually to predict the axial field of view from this prediction. And going to the results here again, so if you look to the plots, so we realized that the technologies tend really to have an axial field of view which is much larger compared to what is needed by the radiologist, because it extends largely over the lungs. So you see, if you use centimeters both in the superior and inferior direction, and then overscanning, overranging occurred 99%, 95% of the cases in the superior and inferior direction, much larger actually in the inferior direction. And if you look to the saving in terms of radiation dose to the patients, so it's 2 millisieverts, which is not negligible, right? So it's equivalent actually to what you get if you make transatlantic flight to New York. So, and then if you look to the thyroid, for instance, as a target organ, so the dose saving is in the range of 67%. This is another example. So again, I think this has been also discussed by the previous speaker, COVID-19, and COVID-19 patients are not cancer patients, so we have to care about the radiation dose delivered to these patients. And of course, the patients were not scanned twice because this is not ethical. So we took basically the standard dose image that you see on the right side, and then we developed a simulator that simulates actually the X-ray CT data corresponding to a low-dose CT scan with the parameters that you see in the table here. And then let me show you some examples. So this is the full-dose scan that is used actually in the clinic. This is the low-dose scan, much reduced radiation dose, but which also degraded image quality. So the image is extremely noisy, as you can see here. And this is the predicted image by the deep learning network, and you see that the image quality was significantly improved, so much better image quality and less noise in the images. This is a second example here, full dose, low dose, and the predicted image, at least for the naked eye, actually, physicists, for me, you have similar observations compared to the image that you see on the right side. But the images were actually provided to radiologists for clinical interpretation, and this was classified as an outlier because the clinical diagnosis changed. So the radiologists, based on the full dose scans, so classified these COVID-19 lesions as ground glass opacities, and the second one as consolidation if the clinical diagnosis changes. This means that this is clearly an outlier. Then we provide the images for image quality assessments. One is interpretable and 5 is excellent. I don't want to claim too much, but you see that the results were really good, so 4.4 compared to 4.7, which is really good. And then in terms of classification of COVID-19 lesions, so the low-dose scan really misinterpreted the number of these COVID-19 lesions compared to what the deep learning network did. A more recent work actually done by another PhD student that you see here, a very complex actually neural network architecture. I'm not going to describe in the detail, but the idea here is to reduce the number of projections, to reduce the radiation dose to patients. As you know, X-ray CT scans use a pretty large number of angles to collect for projections, almost over 1,000 projections. And the idea here is to use a sparse CT reconstruction, meaning that you have a factor of 6 in terms of reduction of the number of angles, and use this complex pipeline here. We call this a dual domain, a sparse view CT reconstruction, because it operates both in the image and the sonogram domain.
You have only 10 minutes. Huh?
All right, that's fine. And these are some images here. So in the thorax, you see the lung window, and this is the abdomen window, and the BIS maps in the bottom here. So what can be concluded actually from this? So this is the reference image. We are a Siemens site, by the way, in terms of PET-CT. We use the iterative admire reconstruction algorithm, so excellent image quality. And this is our images generated by the deep neural network. And these are the noise characteristics. And this is more important information that I'd like actually to discuss in 5 or 10 seconds. You see, this is the confidence in clinical interpretation, the conspicuity and overall image quality. Of course, we're not going to compete actually with the admire reconstruction and the full projection angles, but at least with the factor 6 reduction in terms of radiation dose, we can expect some degradation in image quality, and we are very proud actually of the achievements that you see here. So another development here is to use a more realistic model that enables actually to generate low-dose scans from the full-dose scans that I'm not going to describe here. But let me just show you actually. So this is the full-dose scan, the 100%, and CT scans acquired at different dose levels from 1% up to 80%, and a complex vision transformer that was used actually to predict the full-dose scans from the low-dose scans. And what's important actually in this study is that we managed to reduce the radiation dose to the patients by a factor of 30. So you see this is the clinical quality image in the middle here, 3.1 millisieverts to deliver to the patients, and then 0.11 millisieverts, so significant reduction of radiation dose to the patient. The prediction, of course, is very close to the image quality that you see in the middle. More importantly, actually, if you look to some examples here, so we really preserved actually is very small details, all the textures that is visible in the standard dose scan was preserved by the deep learning network. And what was really relevant to us is that we don't impact the quantification of PET images. If you look to the bias in terms of SUV quantification, it was reduced actually from 8% when you use the low dose scan to less than 0.5% when you use the deep learning network. So the same type of development can be also performed for PETs, and in this case, so the patients were scanned twice with the same injected activity as you can expect. And this is some examples. You see the low dose scan on the left here, the full dose scan, low dose scan, which is not really of diagnostic quality, and the predictions using two different neural network architectures: the residual network, in the left side, and then the cycle GAN on the right side. And again, we went through the same pipeline in terms of image quality assessments by the MDs. Not really important, but what was more important in the study is that we asked the MDs to look to the images, depending on the metabolic activity of the lesions, and to classify them. So we see that the full dose scan, they basically delineated 115 so malignant lesions. The low dose scans, they missed 33 of them. The residual network, only 23, and the cycle GAN missed only 4 lesions. We're not very happy to when we miss lesions, but I can tell you actually for this typical patient, so he had many lesions and didn't really impact the patient management. And this is one example here. Breast cancer patients with a full dose scan. You see, so the primary lesion here, and then the lymph nodes. So the primary lesion was basically depicted by all 4 techniques, but the lymph node was depicted only by the full dose and the cycle GAN predictions. We can do the same stuff also for MRI. There's no radiation dose, but we can reduce significantly the acquisition time. This is neuromix protocol, so with a factor of 12 reduction in terms of acquisition time with the standard multiparametric imaging that is used in the clinic. And Amir, one of the PhD students in my lab, actually spent 6 months in Stanford to work on this protocol. And the aim is obviously to develop also pipeline which enables to generate images that look like the conventional images. So this is one example here. The neuromix on the left side, so the conventional protocol, which takes, as I mentioned, so a factor of 12 more in terms of acquisition time. The deep learning prediction, which improves significantly the acquisition time, and the bias maps that you see on the right side. I think this is very important, especially in when the patients tend to move, patients suffering from neurodegenerative disease, from Parkinson whatsoever, they tend to move to the acquisition. You see one such nice example where the deep learning network actually provided much better image quality compared to the conventional protocol because the patient moves, and also when we have some susceptibility artifacts, as you can see in this second example here. Right, so this is another segmentation example. I think this has been discussed slightly by the previous speaker, so let me just go very quickly. So there's also a large database here for the image segmentation. And the ground truth was basically the segmentation performed by the radiologist. So you see some comparison between the manual delineation, so segmentation of the COVID-19 lesions and the lungs. Maybe you see it better on the 3D illustration here. Radiologist segmentation on the left side and the AI-based segmentation on the right side. And I think, I don't want to claim too much, but I think very good agreements between the two. Another area which is extremely important, especially for radiation dosimetry calculations, as I mentioned it, we have some expertise actually in developing these advanced computation models, humans, and obviously recently we're interested in rodents and non-human primates. For the non-human primates that you see on the right side here, so Tianwu, one of my former postdocs, he has very good knowledge of the anatomy of the non-human primates, but it took him between 6 and 8 weeks to segment those all the organs and to generate the images that you see here. So the idea was to use AI to segment automatically the organs, and we focused actually on pregnant patients. Let me just show you two examples. So the manual delineation on the left side and the automated delineation on the right side. Again, very good agreement between the two. And this work is being pursued by another PhD, H.ZAIDI, to automate the process and to make it actually more competitive compared to what is published in the literature. Especially there's a nice segmentation tool developed by the University of Basel called Total Segmentator, which provides actually very good results. And we managed actually to have better dice, much better dice coefficients compared to this tool. And the good thing is that we also combined adults and pediatric cases. We can also segment pediatric cases compared to the tool developed by the University of Basel. The same type of developments can be used also for PET segmentation. Let me just skip this. Some exotic applications. I'd like just to spend 1 minute. How long time? 2 minutes is okay? 2 minutes is fine? All right, good. So this is really an exotic application in the sense that we have a very active neuroscience program in our facility with the patients being scanned with not only with FDG but also with amyloid and tau molecular imaging tracers. And then clinical decision-making process is based actually on the three scans, right? And then we realized that actually that the early phase amyloid scan with either photobeta-PIR or photobeta-mol is nicely correlated with the FDG. So just to save some time, so we conducted this study actually to predict the FDG from the early phase amyloid. And you see some examples here nicely, the normal, the NCI, and the dementia. So very good results, actually nice biodistribution generated by the neural network. And also you see this on the dice coefficients generated actually on this single phase analysis. So the other application I'm going to skip here is basically attenuation correction. You see that especially for PET-MR, attenuation correction is extremely challenging. And you see actually the commercial solutions, so they simply segment the brain into a single soft tissue component, and they neglect actually all the non-uniformities that you have in the brain, the skull, the nasal cavities, and so on. So the deep learning network managed to generate images that look really like the X-ray CT images. Another example that we face in the clinic that I would like to show you here. We have a number of artifacts actually generated in PET-CT imaging. They could be hollow artifacts, metallic artifacts present in the X-ray CT that will propagate in the corresponding PET images, and also this misalignment between X-ray CT and PET images. And this deep learning framework enables to nicely deal with this. So you see that the misregistration between the PET and CT images that you typically see in 20–30% of the cases that you have in the clinic was nicely dealt with the deep learning framework. And also the hollow artifacts, which is very frequent in gallium PSMA images. The MDs, they usually tend to rescan the patients, hoping that these artifacts will disappear. You see in this case, the artifact was still there, so even with the second scan, and the deep learning network managed actually to get rid of this scan. Let me just skip this. The last application I'd like to mention really briefly is the dosimetry calculations. I had also another PhD students that did really very good work in the sense that the mirrored formalism which is implemented in the clinic tends to neglect the inhomogeneities that we have in the human body, the lungs, whatever actually the tissue difference properties that we have in the body are not taken into account by the mirrored formalism, and deep learning network can generate those distributions which are really close to the ground truth, which is basically Monte Carlo simulations. And for FDG, it's not very interesting, so we expand this framework to cover lutetium for theranostics as well. And let me just skip this last part just to stay within the time limit here. And would like to conclude with this. Yeah, this is the really take-home message. This is Ingrid Dobashies. She's a scientist from Belgium, but working in the US. She says that machine learning works very well, but she doesn't know why it works so well. And she considers that it's really a challenge for mathematicians and also physicists to understand it better. And she believes that if something works, there is a reason for this, and we have to find this reason. So with this, I thank the funding bodies funding our research, and also my group, and with a special tweak for the PhD students who graduated last year, and H.ZAIDI, who's going to graduate within the next few weeks. And then thank you very much for your attention, and my sincere apologies to the chair of this session. Thank you.